Hello and good evening. I'm Jerry Parsons, and I'm going to talk a bit about CBT and stimulant medication. My research proposal is about comparing these two different ways of treating ADHD in adulthood. So let's get down to it. Start at the beginning with some research questions. Um, in adults diagnosed with ADHD, does cognitive behavioral therapy compared to stimulant medications effectively reduce symptoms of ADHD? So, as you can see, my PICO question there outlines, who the population is, um, who, or sorry, rather, what the intervention is, and the comparison that I am going to make, and what the outcome is hopefully going to be. Um, and some of my supporting questions are: does stage of life that diagnosis occurred impact treatment? Are there different presentations of ADHD symptoms across the lifespan? Does CBT work well with all ADHD populations? And does stimulant medication effectiveness vary over time? So these were just some of the questions that I researched while I was preparing for this. Of course, I had some different things come up. But before I get to that, I want to say, here's my hypothesis is that CBT will have as good an impact on symptoms of ADHD in adults as stimulant medications. And then I want to just talk about the theoretical framework a bit too. So for CBT, obviously they are drawing on cognitive and behavioral theories. Like in my research, I came across, Giuseppe wrote in 2016 that CT holds that cognitions bring up feelings, which in turn lead to behaviors, and as such, cognitions are the source of both effective and maladaptive behaviors. Whereas behavioral theory adds to our understanding um, by saying that, in order to understand how thought become action, you have to look at what is what is the human behavior um, preceded by and what happens. So, like, what are the antecedents and the consequences? And once you understand the antecedents and the consequences, you'll understand kind of the behavior. Like, if you really want chocolate, then you'll eat some chocolate and then you'll feel happy you ate chocolate. Like, the antecedent is just wanting chocolate, and the consequence is being happy you had some. Silly example, I know, but just to simplify it. And then in contrast, when we're talking about um, stimulant medication as a treatment, that's kind of more from a biomedical model. Some researchers champion the biomedical model and posit that ADHD is a brain disorder resulting from a deficit of dopamine, and that it is best helped through pharmacological treatment to restore the balance of neurotransmitters. Um, Read that in Sorensen. All these people I'm referencing will be, in the references section at the end. Similarly, some researchers say that both are helpful, not just tackling the biological, but also, the more cognitive behavioral side of things. Frank and Baudry in 2015 um, noted that the theories behind cognitive science are complementary to neuroscience and both help us to understand how cognitions and behaviors come to be. So, point being, you can have kind of some more of the psychosocial aspects, but also some of the biological aspects happening here. And both can impact how ADHD develops, and thus perhaps you could use either or to tackle, helping people with these symptoms. Okay, So I want to talk about methodology real quick, and how we're measuring our outcomes. So this study proposal is proposing that take a quantitative approach. And in order to do that, we would need to have a tool that measures, ADHD symptoms in adults. I found a validated tool called the Adult ADHD Self-Report Scale for DSM-5, ASRS-5 for short, and it asks these 6 questions about, difficulty concentrating, being kind of unable to stay in your seat, um, not being able to relax or unwind. Uh, um, when you're in a conversation, how often do you find yourself finishing the sentences of people you are talking to before they can finish themselves? Um, and how often do you put things off to the last minute? And finally, do you depend on other people to keep your life in order? As you can see, I got a little distracted at some point, and question 5 is out of line from all the others. But yeah, that's kind of maybe a little bit of my ADHD showing. Okay. So now I want to talk about sampling frame. So for this study, propose it should be a non-probability approach, purposive. So when I'm like looking for people I want to involve in my study, I have to be more specific than, do you want to be in my study? Because I'm really targeting ADHD, and I want to, you know, work with people, adults who have ADHD. So in that case, I can't just take anybody from the population. And then I want to, on the second step, kind of like once we have our base amount of like all the people involved who have ADHD are adults and are willing to be a part of this study, have more of a randomized controlled trial approach. So let me talk about that a little on the next one. So, about selecting people, my thought is that I would go to some chain or a number of uh, different mental health clinics in New York State and put up flyers requesting, adults who have ADHD who want to take part in a study, and preferably haven't had too much treatment as yet, just to avoid sullying the results, like maybe they already have been treated, and so adding this new treatment isn't going to be a good measure, for them specifically. So have to do a little bit of interview with them and probably, make sure they actually have an ADHD diagnosis, maybe. Yeah. So, and yeah, just looking for volunteers that we're not going to be doing anything to pay them back. At most, like if we were to do anything, I guess we could give them a coffee gift card or something like that. All right, now, so like I said before, I want it to be a randomized controlled trial. And in order to do that, once I have, all the people who have volunteered, I need to split them up into 2 groups. In order to make it more random, I would want to split up the groups of people in a kind of purposeful way, where each group has similar diversity. Like, don't want group A and group B to have like all of group A is women, all of group B is men, because that could influence our outcomes. So would want to do some amount of, tailoring this grouping of people. So maybe matching, by age and gender and that sort of thing, like into other groups, and then pairing them off into the intervention group and the comparison group. And so the way I would plan to conduct this trial is to make sure I start off by doing the ASRS-5 with everyone involved, whether they're in the intervention or the comparison group. So that way we can see what the baseline is for everyone. And then my proposal is that the intervention group would be receiving CBT treatments for 3 months, whereas the comparison group would just be getting stimulant medication for 3 months with, some consultation with a psychiatrist to manage it, that sort of thing. And then once those 3 months are up, we would do another SRS-5 with everyone to see how their symptoms changed after 3 months, rather. And then finally, I want to see if the treatments have any sort of staying power. So after all the interventions are done and everybody's been, done with the study, 3 months later, hit them up again, complete one last ASRS-5. Okay. I hope that all makes sense. Yeah, let's keep going. Right, so my final thoughts on this. I wanted to talk about the limitations and the implications. So for limitations, some of the stuff I read in the research that I mentioned before is that some diagnoses of ADHD in adulthood might be different than others. Raga Jopal et al. In 2022 mentioned that some diagnoses indicate a biological factor for later in life diagnoses. They did some comparison of genes and found certain ones were associated with it versus when you were diagnosed as a child, there were more of this other kind of gene. But in contrast, Sasaki et al., also in 2022, believe that the difference between people who were diagnosed as children versus adults is that the people who were diagnosed as adults were able to mask better because it could have been any number of things, more social factors, or that sort of thing, instead of a biological reason. And wanted to add, the implication of this is, if it's more biological, it could be that doing stimulant medication or something that impacts, the physical might be more useful than something that tackles the mental health, coping skills, that sort of thing that we teach in CBT. Whereas if it is really just that, maybe people who were able to mask for a long time, all of a sudden they all had these things that became overwhelming to them. Maybe they just need some new coping skills to learn, and CBT would be sufficient. So yeah, want to know which it is, is it more about the biological or the psychosocial? And if it is one or the other, maybe CBT would work better for the group who have a more biological reason for developing this in later life, or people who just got overwhelmed because their masking wasn't able to keep up might benefit more from CBT interventions. Okay, other limitations are that it would be a small sample, and drawing on people from a single state may not really be representative of ADHD in adulthood overall. Certainly unlikely to be, representative of what that presentation might be in a different country, or a different, financial, social environment. Hard to say. And also I wanted to say about limitations, the fact that I'm drawing on volunteers who would already be in a mental health clinic and looking for help might mean that they're more motivated, or, have more internal strength to work towards this sort of thing at the moment, and thus they might not, again, be representative of the population as a whole. Yeah. And then I wanted to ask, like, as far as implications for further research goes, are these, things, these limits that we're trying to understand, if it's biological, if it's psychosocial, are there other confounding factors? Is gender the most important thing? Is age the most important thing? Are there other factors that we haven't even thought of that might be impacting? Like I just mentioned a second ago, I was trying to get to it, but like financial concerns. Maybe if you come from a higher socioeconomic background, you're able to handle ADHD until you are an adult. Um, it's really, it's hard to say, and there would have to be more strenuous ways of collecting a sample to study in order to be sure. So I think that's pretty much all I had as far as limitations and implications go. So I'll just say thank you for viewing me while I prattled on about this stuff. I hope that you enjoyed learning about it. And here you go. Here's my first page of references and my second page of references. Um, yeah, again, I hope you enjoyed it. And I'm going to stop the sharing here so we can come back here and just say thank you again for watching. It's been really great getting to learn with all of you. Getting a little sappy here, but I'm glad we all got to do this together. And I look forward to viewing your presentation as well. Bye.